Hello, and welcome to today's webinar entitled Steroid Use in Duchenne, Expert Dialogue on Latest Data, presented by Cure Duchenne. Your webinar will begin shortly. If you have any questions for the presenter during the webinar, they can be submitted by using the chat box. Type in your question to the presenter, click send, and it will be addressed during the question and answer session immediately following this presentation. If you are disconnected from the webinar, you can re-enter the program at any time by following the instructions that have been provided to you. If you are still having difficulty connecting to the webinar, you may call our technical support hotline at 1-877-992-7225. Again, that phone number is 1-877-992-7225. Now at this time, I would like to introduce Deborah Miller, the founder of Cure Duchenne, who will open today's program.
Thank you, and good evening, and welcome to Cure Duchenne's webinar series. Tonight's webinar, Steroid Use in Duchenne, will be hosted by Dr. Ciafaloni. Dr. Ciafaloni is a professor of neurology and pediatrics at the University of Rochester Medical Center, who specializes in the diagnosis and treatment of neuromuscular diseases in adults and children. She's the co-director of the MDA Neuromuscular Clinic and program director of the Neuromuscular Medicine Fellowship Program. She graduated from medical school at the University of Milan in Italy in 1989. And Dr. Ciafaloni trained at Columbia University in mitochondrial diseases, then at Duke University, where she completed her neurology residency and neuromuscular and EMG fellowship. Dr. Ciafaloni's current commitments include improving the diagnosis and treatment of adult and pediatric patients with neuromuscular diseases, especially Duchenne muscular dystrophy, myasthenia gravis, ALS, limb-girdle muscular dystrophies, myotonic dystrophy, FSHD, and spinal muscular atrophy. She has national and international expertise in conducting clinical trials in adult and pediatric neuromuscular diseases. So she also has extensive clinical research interest in the best treatment of patients with Duchenne, the course and outcome of pregnancy in women with muscular dystrophies, and sleep disorders and neuromuscular diseases. We're fortunate to have her with us today, and I'm happy to turn the program over to Dr. Ciafaloni.
So welcome to everyone, and I just want to say that today's program is intended for both treating physicians or healthcare provider, neurologists, and other subspecialties that treat Duchenne muscular dystrophy, as well as parents and other caregivers, and teens and young adults patient with Duchenne. And the format of our program is really meant to be a dialogue and a discussion among experts. And by expert, I will introduce you soon to the speakers. And it's very important, we also want your participation, the audience, so with interactive polling and questions throughout the program so that we can focus more on what is really the you would like to get out of this discussion. So the objectives for this hour are really to understand the role of corticosteroids in the treatment of Duchenne muscular dystrophy, and to really become more educated and aware about the risks and benefits of corticosteroids in Duchenne, gain the information required to make a more informed decision about the use of corticosteroids for these patients, and to learn how to best mitigate the side effects of corticosteroids. So how to respond to the polling question. I will be reading the question to the audience, and then you will be able to click your response, and we will see the cumulative results, and we'll take that into the discussion. And also, you'll be able to submit questions as previously explained, so that at the end of the program, we can actually address your questions. So, for the first round of polling questions, This is for family and patients. If you have Duchenne, how old are you? If you care for someone with Duchenne, please indicate patient's age. And if you care for more than one boy with Duchenne, please tell us about the eldest brother. I'm going to give a few seconds for seeing the responses. So, okay, so it seems like about the majority of the audience is between age 5 and 9. That's about 50% between 5 and 9. But we also have about 20% or so older than 16. So let's keep these in mind for our discussion. Can we move on to the first question for the HCPs? Okay, what best describes your specialty? And this is for the healthcare provider. Are you a neurology, neuromuscular, cardiology, pulmonology, pediatrics, family medicine, nurse practitioner, or physician assistant, or others? Okay, so this seems like the vast majority, 70% or so, are most likely general neurologists. So that's very good to keep in mind. And then we have the second most common is pediatrics. So neurology and pediatrics, excellent. So we're going to we're going to keep that in mind. And now I would like to introduce my esteemed colleagues, and I would like to say friends. These are the people that I go to ask questions when I don't know the answer. So we're going to start with Dr. Branzima. If you want to go ahead and introduce yourself first.
Sure. Well, it's a great pleasure to be here. My name is John Branzima. I'm the neuromuscular section head at the Children's Hospital of Philadelphia, and I'm happy to be part of the panel this evening.
And maybe if you can just tell us, John, and then everyone else, just approximate number of Duchenne families currently under your care, and maybe just one pearl of wisdom about this topic that you have learned with your many years of experience. What would you say?
Well, we're very fortunate here at CHOP to have a large neuromuscular program. So we have 6 neurologist providers caring for our neuromuscular population. Between those 6 providers, we follow over 300 patients with Duchenne muscular dystrophy. Myself personally probably have seen around 75 of those patients. And I would say that the thing that I learned the most is that you can't use one paintbrush to paint everybody living with Duchenne or their families, that really this is a spectrum of disease that affects everybody a little bit differently, and you have to keep that in mind with any possible interaction with somebody living with Duchenne or with their family.
Excellent. So personalized medicine. Kathy? I think we have lost Kathy. I can't hear her.
Let me try again.
Yes, now you're loud.
Can you hear me now?
Thank you, yes. Start over.
So I actually looked up how many years I've been doing this, and I've been an MDA clinic director for 23 years. I, at any given moment, together with my colleagues, follow between 100 and 125 patients with Duchenne. And I think I loved what John said, and I completely agree. And I think my sort of observation over the years of doing this is that I'm continue to be impressed with how care has improved. Steroids is certainly a big part of that, but care has improved and outcomes have improved over the years that I've been taking care of boys with Duchenne. So hope that that is continuing, and I see that continuing.
So I think we will all say that the learning curve continues for all of us. Even having done this for so many years, we're still learning every day, especially from the family and patients' feedback. And next, we have Susan Turner. Thank you for actually being here with us. I really appreciate. And tell us a little bit about your experience with Duchenne and maybe what you have learned that you would like to share quickly with the audience.
Hi, I'm Sue, and I'm a parent of a 8-year-old with Duchenne. Thank you for letting me be here. I think, like you guys all said, it is a learning process. Even with us, we've only been 4 years in since he's been diagnosed, and every year there's something new coming out and more information available to our boys, which is it's a very exciting time.
And speaking of which, this is just to give you a flavor of the wonderful family, and this is him. All right. Let's start talking kind of introducing the concept of why corticosteroids are so important and the use of corticosteroids in Duchenne. And I would like to read the second question for family and patients. What do you most want to know about steroids and their use in Duchenne? Is it effectiveness, long-term safety, tolerability issues, how to reduce side effects, practical issues, how are they taken or administered, the cost, or any other? So it seems like the two most important, actually the most important is reducing side effects. So side effects is an important topic for discussion, and then of course effectiveness. So we can move on now to the question number 2 for the healthcare provider. What percentage of Duchenne patients in your care are you managing on steroids? Less than 20%, 20 to 49, 50 to 80, over 80%. Okay, so I would say that we have the majority are true believers, over 80% or between 50 and 80%, but we do have a portion, about 25% that treat only less than 20% of their patients. So that's good to know. So moving on. So let's start. All data, good, strong data about the use of corticosteroids in Duchenne muscular dystrophy. Where does the data come from? How good is it? And why is it so strongly put even in the most recent care guidelines that were recently updated? Maybe we can start with John. Can you tell us a little bit about where does that effectiveness data come from and how good is it?
I think to start, just the term steroid really is used in a lot of different ways by folks. You can refer to steroids, to corticosteroids, to glucocorticoids. These are all really different ways of saying the same thing, which are hormones that are produced naturally by our body, by the adrenal gland, but are known in the context of a medication where we give it exogenously or outside the body through a medication to have anti-inflammatory properties and also other things that stabilize the muscle membrane. And this is why they've been used in a disorder like Duchenne muscular dystrophy, where the course is of inflammation and damage to the muscle over time. So we've used them for a very long time, since about the 1980s. And throughout that period of time, various people have looked at the effect of steroids on the disease, either by just following the patients that they see in the clinic in a way that's prospective or that collects data from a certain point in time onwards, or they set up actual interventional trials where they start with people who aren't on steroids and compare people who start steroids to those who do not start steroids. And then there's a third way of looking at things, which is when you have a question, you look backwards and you say retrospectively, what is my experience with steroids in this particular population? So we have publications from all of those perspectives in Duchenne muscular dystrophy related to steroids. And the two main steroids that we've been using all along are either prednisone or deflazacort.
So it seems like we have some good trial-based data, but also it's very important to also rely to personal experience, being from the doctor or from other parents and patients who have been doing it for longer. But that's where some of the data in the guidelines that have been published. So can you tell us, John, again, like going over briefly just the main strong effect of corticosteroids? What do we know about corticosteroids? What do they work on? Here are slides that kind of summarize some improvement in survival, muscle function, which I think is predominantly delaying loss of ambulation, and then pulmonary function, delaying scoliosis, and delaying cardiomyopathy. Do you think that these cover kind of the main effectiveness points?
I think it's important to realize that we do not have a cure for Duchenne muscular dystrophy at this point. And the therapeutic option that has the most experience behind it is steroid therapy. So the theme is in Duchenne muscular dystrophy, we have a disorder that causes progressive loss of function over time. Steroids tend to delay milestones in this disease. As I mentioned at the beginning of the talk, this isn't one experience for everybody, and so it's going to be different depending on your own experience of Duchenne, what age you are when certain things happen in the natural progression of the disease. But what happens with steroid therapy is that tends to get pushed back a little bit. So if you compare people who have taken steroids to people who haven't, on average, somewhere between 1 to 4 years later, a certain time point will happen. And that's true of all of the things that are on this slide here, now that more and more data is coming out. Because initially, most of these data related to steroids was looking at its effect in younger boys with Duchenne who were still ambulatory or walking. More recently, more and more data has been coming out about people living in the non-ambulatory phase of the disease, which tends to be anywhere from the early teenage years into the late teenage years and sometimes even young adulthood. And in that phase of the disease, the other aspects of muscle function that start to get more affected, like heart function and lung function, become much more significant later on. And steroids still have an impact at that phase of the disease as well.
Yeah, I think that's an important point, especially I know in the audience we have some older patients and families. The pulmonary function cardiomyopathy, delaying those is crucial, and we know that now patients with Duchenne muscular dystrophy live much longer. So those are very important. Now, Susan, let me ask you, when did you first hear about corticosteroids after the diagnosis of your son, and how did you come to the visit? Did you already have some knowledge about corticosteroids? Were you completely naive? And how did that interaction went? And how did you ultimately decide to make the best decision for your son based on what information?
So Levi was born in 2010 and had a normal birth, normal milestones. He wasn't really delayed, but he was very weak, couldn't keep up. So in 2014, at his 4-year-old checkup, one of the physicians, the main physician that we go to, Linda Stidham, she did think something was off, and he showed signs and symptoms of Duchenne. So as a parent, I I went home and researched. As a nurse, I knew that it was generalized weakness of the body, but I didn't know the intensity of what Duchenne encompassed. So I went home and I researched and I looked and I found a lovely advocate of Duchenne named Jen McNeary out in Massachusetts, and I called her. And so my first experience was with the more knowledge of Duchenne and corticosteroids was actually with another parent who gave me her experience on what she's been through. She has 2 boys, and one of the first things was you might want to consider some steroids. That's what they'll ask you. So I went into that, and with as a mom going through that, you're looking at all the side effects, and you're having to weigh whether you want to put your child on that. But then the pros for our family, and it's specific to each family, has to make that decision what's right for their child. For my child, I believed that putting him on something that will stabilize his muscles and give him a little bit more of a longevity of walking possibility was a huge benefit.
Was there anything that you wish it was communicated to you in a different way between starting steroids, or anything that you will recommend that maybe was missing in that conversation? Then we're going to follow that by, I want to hear how Kathy does it when she first has that in conversation with families and parents about starting corticosteroids.
So we first met with you, Emma, and you gave us the idea of starting a corticosteroid, and you gave us all the side effects and all the benefits and the pros and the cons, and really put it in our lap. And
then you put that together with what your homework. It seems like you came quite prepared, which is good. And so you digested the whole thing, and then you made the best decisions that you thought for your son. Kathy, how do you approach that first conversation about the benefits and the side effects of corticosteroids? What is your ultimate recommendation in let's say, in a young, newly diagnosed patient, and any discussion regarding the 2 options, prednisone, the Flazacort? You're still mute, so we can't hear you.
You're going to have to just keep reminding me.
And now you're back.
I bring up steroids in the very first visit when I'm, doing the long conversation about what is Duchenne muscular dystrophy, what is the pathophysiology, and what do we have to treat it. So in that very first conversation, where I think parents often don't hear anything after about the first 15 minutes, I at least introduce the steroids then. Correct, Susan? And I go through exactly what Susan said you do, Emma. I talk about the fact that we have, I would say, pretty overwhelming evidence that steroids change the course of disease, that we have data from hundreds of boys through a number of different studies that have been well done that say that steroids on average are beneficial and slow the progression of disease. One of the things that I like to mention is, although we talk about, and this is reiterating what John said, is that although a lot of the data has looked at 6-minute walk test, and when parents do their research and go online like Susan did, they often end up saying, well, so it says that they walk another year or 2 or 3, so what? That's, I can live with, it doesn't really matter. And I think one of the things that we emphasize is that it's not just walking, that it's walking plus all these other benefits, that some of which accrue from walking longer and some of which are independent, probably benefits of the steroids. So, and then I do go through the 2 major classes of steroids, or types of steroid, deflazacort and prednisone, and outline the relative risks and benefits. So we know that the side effect profiles are different, and we go through those.
So, good. So family question number 3. How long has your son been on steroids, either with or without dose adjustments? We do dose adjustments, of course, based on the severity and number of side effects. So it seems like the majority, well, we are pretty much split between more than 3 years and less than 1 year. So someone just still new to steroids and then a little more than 3 years. And moving on to the question number 3 for the healthcare provider, how familiar are you with the recently published data by Perry Shea et al. In the July issue of Muscle and Nerve on steroids used from the ACT DMD trial? We're now talking about more recently published data in regards to corticosteroids, and that's what we're going to talk about next. So it seems like 50%, so the majority are not very familiar with these new publications, and some are very familiar. So moving on to family question. We have another family question number 4. What is your overall impression of steroids use in Duchenne? Positive but at a cost. Okay, frustrating, lots of tolerability issues, not worth it. Okay, so I would say that mostly realize that they have positive effects, but it comes with the cost, and the cost needs to be managed. But I think that everyone thinks that is definitely important. So maybe let's move on to the next slides that tell us a little bit about the loss of milestones. And I think it is kind of relatively new data. If we can show that slide with the loss of milestone by glucocorticosteroids. There you go. So, John, can you tell us a little bit about these slides in more lay terms? What does this tell us about the advantage of using steroids versus no steroids?
This is a large cohort study, international cooperation called Synergy. And this group collected data about their patients that they were treating with Duchenne and for 10 years in this publication. So it's a lot of experience in many children and teenagers and young adults living with Duchenne muscular dystrophy. And what we're looking at specifically on this slide is looking at the age at which a certain milestone is reached in the disease, loss of ambulation or loss of upper limb functional milestones. And what you can see is the dark blue are people who essentially didn't take steroid therapy, and the light blue are people who took steroids for over a year. And there's a clear movement towards the right of the slide, which is time, with the steroid therapy. So you're delaying the time point that these things happen, on average somewhere between 1 to 4.5 years in this particular cohort study, showing a benefit of steroid therapy in delaying loss of function in Duchenne.
So this is a large cohort, 340 patients, so that's quite significant. And maybe, Susan, do you want to comment, what did you see in your son in the early on stages on corticosteroids? I know that you don't have the perspective of, these other milestones, but was there anything that you noticed early on or so far that you think is positive?
Yeah, actually, when he first started, into the whole deciding on the steroid, Levi could not jump. He could not lift his toes up off the ground, and that was a concern to us. He'd go up off an inch to the porch, and he'd fall, and he'd hit his head. So he would lose his balance. His coordination was off. He couldn't jump on a trampoline. So we decided to put him on deflazacort. Basically because I did some study on prednisone and deflazacort, and the choice that I had made for Levi was deflazacort. Newer, supposedly less side effects, but again, each child is affected completely different from, there can be different side effects. So with Levi, he's shown side effects of Hirschism, he has more hair on his neck and on his legs. And finally, after, I think he's in his 4th year of deflazacort, and he's starting to get the little steroid cheekies, but nothing bad. But he can jump. Within the first year and a half, we've noticed he could, on the steroid, he was able to jump. His toes came off the ground. He was able to jump on a trampoline. His balance was better.
So this is very important. Basically, we have some short effects that you can notice pretty early, and there is good data about that, especially the jumping and other things. But then we're looking at very long-term, 10, 20 years down the road, what are we really gaining? And that will become important when we discuss the side effects. Any other comment? Maybe Kathy, do you want to comment about these slides? Again, this is the ACT DMD recent publication comparing deflazacort to prednisone. What does that add to the body of data about corticosteroids? What do you think?
So this was a very interesting study, and it goes to show for those parents who are in clinical trials, we use data from clinical trials in ways that you don't necessarily plan up front. So this is taking data from a clinical trial on a drug that is not a steroid, and they took those who were in the placebo arm, and they, by chance, were almost randomly distributed or evenly distributed between those whose where the family had chosen to take deflazacort and those who had chosen to take prednisone or prednisolone. This was retrospective, so as John mentioned earlier, it wasn't something that they were randomly assigned to either deflazacort or prednisolone or prednisone. It was what the family had chosen. So they're not, it doesn't have quite the power of a prospective study, but because they were fairly evenly divided and the data had been collected in a very rigorous way, they were able to go back and look at the change in over a year of 6-minute walk time, which is one of our standard outcome measures. So it's how far can you walk in 6 minutes. And the boys on deflazacort walked farther at 6 minutes or lost less distance than the boys on prednisone at the end of a year. So it's one of these accumulating pieces of evidence that suggests that deflazacort may be may have more benefit on retaining ambulation than does prednisone.
So this is one piece, this paper, and then the other paper is, again, going back to the Synergy Group publication, and this is their summary slides about loss of ambulation, the age of loss of ambulation by deflazacort in the lighter blue versus prednisone. John, do you want to comment on this? This is fairly new data as well.
Yeah, so this is again from that international cooperation, the Synergy Group, looking at the percentage of patients who are ambulatory by age, and you can again see in the light blue that the deflazacort patients are ambulatory on average longer than the patients on prednisone. I do want to mention one important aspect of this sort of research in the United States, which is that deflazacort previously to the FDA-approved label that happened about a year or two ago now, was much more difficult to access for families than prednisone in the United States, that it needed to be imported from other countries, and there was an expense issue. And so a lot of times when we're looking at our United States-based data, there's a concern that perhaps families that opted to use deflazacort may have also had more access to other aspects of Duchenne care that might have had issues related to accessibility. You always have to keep in mind that both this synergy group and also the data that Dr. Matthews was presenting from the ACT-DMD trial does have an international component to it. And on the international landscape, the two steroids have been fairly equivalently available. I, for example, trained in Canada as a resident, and there it was relatively interchangeable using deflazacort versus prednisone with your prescription, and so it was really up to your discretion which one you used. Whereas I found when I moved here to the United States, it was very much about what the family could actually manage to do in terms of the accessibility. And even now that we have a label for deflazacort, there's still not quite the same equivalence in terms of accessibility there. So we do have to keep that in mind when we're looking at this data.
Yeah. So, and this is a little bit more like we're going to talk about side effect frequency of physician-reported side effects, the prednisone versus the deflazacort. And this is, again, that study of the previous slides. And this is the report on the different. So would you say, Kathy and John, that we tend to think of the deflazacort as having more effect on growth retardation and cataracts, and prednisone, though, has more side effects on weight gain? Would you agree that that's probably the main? And then again, every patient is different. It's nice to have two options, but would you say that that summarized the main side effects of each? Kathy?
Yep, that's the summary that I give.
And John, you agree?
I do. I would say that anytime you're trying to compare the two steroids, you also have to keep in mind the variability of what people are actually taking. You know that we have a lot of different approaches to using steroids in Duchenne. Some people take steroids every day. Some take them only on the weekend. Some take them for 10 days on and then 10 days off. There's lots of different schedules. And then not everybody is on the same amount for their weight either. You know, we have an ideal dose that's suggested based on the early research in steroids. But some people can't tolerate that high dose for whatever reason, or have other factors that lead to them going on a lower dose. And so when you're saying, I'm comparing people on prednisone to people on deflazacort, are you really comparing equivalent in every other way? That's very hard to achieve, because this is a rare disease, and you get to smaller and smaller numbers the more you try to match people exactly. So that's one of our challenges when we try to interpret our experience with these two steroids.
Yeah. So going a little bit inside the facts, here is family question number 5. If your family has steroid experience, which side effects, if any, is the most bothersome to your son or your family? Is it behavioral changes, weight gain, acne, facial hair, delayed growth, others? You know, this is a very important question, because I think from other diseases in medicine, we know that sometimes the healthcare provider think of the worst side effects, and when you actually ask the patient or the family, their view might be very different on what they consider the most bothersome side effects. So I think that the big one here is weight gain and delayed growth. And those come with actually both corticosteroids, maybe a little bit more weight gain with prednisone, delayed growth with the deflazacort. So moving on to the health provider. So as a healthcare professional, which one side effects of steroids used in Duchenne is the most worrisome to you? What do you worry most when you write the prescription to your patient? Okay, so it seems like bone. So concern about osteoporosis and fractures. So that is very different than the patient. So moving on to the next slide. Susan, so what was the most concerning to you of this side effect? When you first heard about corticosteroids, say, oh, this is really for me, for my family, for my son, I really think that I'm most concerned about this. Which one of these listed here on this slide?
I believe in the beginning it was definitely weight gain, and I don't know that it was more because of aesthetic. It wasn't because I was concerned my son would be picked on or anything like that. More so, I guess not that he would be picked on, but just the weight gain and change of lifestyle with that. But now it's actually changed. 4 years being on the steroid, I'm actually more concerned with his growth delay.
So I see the flavor here is a moving target. This is very important. Duchenne covers a spectrum of life, so from very young and so forth. And so I think that there is a discussion about steroids at the beginning, but really the discussion is a continuous and should be readdressed every year at least, and regroup and change course as needed. John, do you want to comment maybe on the side effects in terms of maybe also which side effects would be most compelling, and also just a word about that this is a chronic therapy for many, many years, and some word of wisdom about in case of discontinuation. Are there any risks with that?
Yes, I probably would break it into different moments in your experience of Duchenne in terms of what tends to be the biggest issue for the families and patients and also for the providers. So when people are first starting, they're typically around school age or just before school age. And the side effects that tend to become an issue are the behavior effects or the effects on weight and change in cosmesis. So, in that age group, sometimes it's hard for the boys to be different than their peers, and that can be very hard on them socially if they're getting teased a lot at school or other things. But the behavior change can be a big issue. A lot of our people living with Duchenne do also have some behavior problems or attention problems at baseline before they start steroid therapy, and it can make things worse. Not everybody living with Duchenne has those issues, but about third of patients who do, it can become a problem. And that's where maybe lowering the dose or going to a different schedule like only weekend dosing can help with those kind of problems. I think another time point is the transition from being ambulatory to non-ambulatory. I think that comes at a time of life in a lot of boys' experience of Duchenne when they're starting to get their own sense of identity and who they are as becoming an adult person. And sometimes they have a voice in whether they want to be continuing this therapy or not, that they start to express at that age. So I think it's really important to have open discussions about why this is important and what you might be thinking 15 years, 20 years down the road. This kind of thinking is hard for any person, but especially teenagers to do. So you really have to spend a lot of time trying to explain why this might still be important. And then we get into more and more issues with the bone health problem, which anybody living with weakness is at risk of their bones being more fragile. Also, when you have mobility problems and are falling, it's more of a risk that you're going to fracture or have other injuries, which can really impact your quality of life living with neuromuscular disease. And being on steroids does make the bone even more prone to that. So we have to be so careful to supplement with vitamin D and calcium all the way through and keep a close eye on things like x-rays and DEXA scans to see whether it's time to intervene for the bone health. And then the last point I think you had brought up is the issue of being on steroids for a long time. If you were to suddenly become stressed when you're adrenally suppressed, because your adrenal gland normally makes these steroids for your body, but if you're taking steroids as a medication, it stops doing that. And so it doesn't have the drive to respond to stress the way that it should. This can happen to anybody on chronic steroid therapy. When they become suddenly very sick, they can have a stronger reaction to that than if they weren't on steroids. But it's also important to keep in mind, if you decide to stop steroids, that you have to do it in a very gradual wean, but then also think about this issue of adrenal suppression even for a period of time after you've stopped the steroids, that you're still at risk of having this kind of reaction. And many of us are now prescribing a stress dose of steroids for our patients to give in a crisis situation while they're seeking urgent medical care if they're having any of the symptoms that you can see there on the slide related to adrenal crisis. So this is something very important for any general provider in an emergency room or a family doctor. Sorry, my lights just went off in my office. But a family doctor or a pediatrician caring for these patients to keep in mind.
Yeah.
And I'm going to get my lights.
Those and don't stop if they're sick, and keep that in mind. Just to conclude, and then we're going to move on to opening to the question and answer. One pearl about weight gain. What do you tell your family, Kathy? This is a tough problem, weight gain. I usually tell them, the whole family go on a healthy diet, meaning no sodas for anyone in the family, not just the patient, no sugary stuff. It has to be a family commitment, not just the patient. What is your best recommendation to handle that one?
I certainly agree with you on that. And then I also encourage them to work with a nutritionist who can sit down and spend the time to find out, what does your son like to eat? How can we still make him happy and be able to eat the things that the other kids are eating, but manage that weight gain? So I think regular discussions with the nutritionist can be helpful.
All right, thank you. And now I think we are opening up to question and answers. And I have some that just came in, which I think is very important. The question is, what are the risks of starting too early? And I will complement the question saying, when really is it recommended to start corticosteroids? We haven't touched on that. What is the best time? When should we start talking about age at starting corticosteroids? John first, and then Kathy.
The recommendation has shifted slightly in the new care consensus guidelines that came out earlier this year. It typically in the past was at the time of a plateau in the motor development or the early start of the decline in motor function. But now the care consensus guidelines say around the age of 4, which for many patients is before they've reached that plateau phase in their disease. There's also some research being done in starting steroids even younger, and there's some data that's going to be coming out about using steroids in very young patients with Duchenne. But that data is still pending, and there's a lot of discussion about that. It's not routinely recommended to do that. It's something that's being done on a research basis.
Kathy?
I agree that I don't think we have any longer a sort of hard and fast guideline. I think that you discuss with the family the relative pros and cons. I tend to start earlier, on the earlier end, but some families are just not ready to. So sometime in early childhood, 3 to 7 at the.
Yeah. Another question came in, which is quite interesting. Are there any other experimental corticosteroids in development, John, as there's been some talk about maybe corticosteroids with less side effects? Is there anything in the research pipelines?
So one alternative that is currently being studied and very close to having data presented in a journal, my understanding, is something called vamorolone, which is a dissociative steroid. It's related in terms of how it works, but it's more targeted in terms of how it actually reduces inflammation and that sort of thing. and is meant to have less of the side effects that are undesirable with the same effect. That's the idea behind it, but we don't yet have enough of the data presented to be certain about that. There's also research being done on entirely different mechanisms looking at inflammation. There's been a research trial by a company called Catabasis that's been going on for a while, looking at another way of inhibiting that inflammatory pathway that has nothing to do with steroid effect and may have none of those associated side effects. But these are all research-based. I would also mention the concept of when to start steroids has become complicated by the research landscape because some trials require you to be on daily steroid use, whereas other trials want you to be steroid naive. And so navigating that in terms of what families are decision-making when they're thinking about whether they want to participate in research makes the conversation even more complicated.
And speaking of that, a question came in that what is the evidence supporting use of steroids with exon-skipping therapies? There is now one exon-skipping therapy that is FDA approved, and what can we tell about that? Steroids with Exondys 51, and I know, Susan, you know, your son has been in trials for a long time, but Kathy, what do we know about that, exon-skipping and steroids?
So the studies, the phase 3 study is still ongoing, but the studies that have been done have steroids and Exondys 51. So I think that for many of the drugs that John mentioned, there is an additive effect. As John mentioned again earlier, you did too, I think we don't have a cure, but serial things add on to each other, and the evidence that we have is that Exondys is additive with steroids, or at least there's no reason not to use them together.
Okay, this is an important question. There are a couple of questions that came in, say, you know, how long do we use steroids? Is it long-term? But here is an important question. My son's cardiologist told us the long-term use of steroids will harden his heart arteries over time. Is that accurate? And, you know, maybe we can go, John, can you answer, is there any reason that long-term use of corticosteroids is contraindicated for the heart?
In fact, it's the opposite, that if you look at the data that is out there from groups like the Synergy Natural History Group, the heart function is more preserved in the patients who are on steroids compared to those who aren't. Now, it didn't reach clinical significance with the statistics that they used in the particular Synergy paper, but each publication that has looked at this issue from a heart perspective has come to the same conclusion of the steroids being of benefit. And this is true also for lung function. It's true for the progressive curvature of the spine, or scoliosis, is less severe in patients treated with steroids. So all of these benefits are seen in our data that we have about steroids.
So there is more and more data saying that cardiomyopathy is going to be delayed. I believe that the only absolute contraindication or need to discontinue steroids might be in overt heart failure, perhaps. But other than that, I think that all the advantages stand. Next question. Someone was asking, is there any interaction between corticosteroids and any of the common supplements given to Duchenne kids, such as calcium, CoQ10, fish oil, vitamin D? Is there any reason why those should not be given at the same time as corticosteroids, few hours before or after steroids? Does it matter at all, Kathy?
I would say that many of those supplements that you listed are things that are given to help counter some of the side effects of steroids, and so we give them together routinely. I do not know whether there is any specific absorption problem that would mean that you should give them separated in time. I think families very routinely give them together.
Right. So, and someone wanted to share an experience of their son who have received the Flazacor since the age of 6, and he just turned 29, so congratulations. That is wonderful news. Unfortunately, he has had some issues with kidney stones and infection with bladder infection. John, is that something that we see in Duchenne, kidney stones, infections of the bladder?
Yes, this has been described, and it does happen in people who have never taken steroids as well. So it's something that can be seen in the later phases of the disease, particularly.
And someone is asked, how come that the benefits derived from the same steroids regimen might differ from one boy to another? And I think this is important. We love when parents talk to each other and share experience, but you can direct everything to your particular son because it's different. What can we tell them? Why is that? Why do patients react different to different medications? That's really true for many other. Kathy?
We all come to the world with different genetic backgrounds, and our response to medicine is determined by a lot more than just whether we happen to have a mutation in the Duchenne dystrophin gene. So I think a lot of it probably has to do with interpersonal variability that we just don't have the means to test right now.
There is a fancy term, right? Pharmacogenetics. Also, people have different genes that affect the way we respond to medications. So it's very complicated. That's why, like we were saying earlier on, every patient is really an individual and can respond different. What is, maybe this can be our last question, what is a healthcare provider best advice for reducing the side effects of steroids? Susan, maybe let's start with you. What would you say you have found for your family? What has helped you the most to deal with the side effects? How did you work it out in your family?
Well, the Hirschism, the extra hair, we were able to shave off the area in the back of the neck. The weight gain, the little bit of weight gain, isn't really affecting him really that much, but we do watch we monitor his weight, and we watch nutrition, and we're active.
Yeah, and Kathy and John, last word of wisdom about side effects. Kathy?
Talk to a nutritionist.
Yes.
And monitor them and respond early when you start to see a problem.
Yeah.
If you
John?
can, if there is a response.
I would just say, please come to clinic. We have these big teams of people that really want to help and watch for the things that might be issues in this disease. And we're trying to think of the person living with Duchenne as their own person and what's the right choice for them. So we're going to work with you together as a family or a person living with Duchenne to come up with the right answer for you. But we can't do that if we don't have the information. So we need you to come see us so that we can talk about it.
That's why multidisciplinary clinic, that is not just one of us, like John or Kathy or myself. We have a whole village with the best expertise about diet, about bones, about growth, and we use them and usually take advantage of those subspecialties. Well, I think it has been awfully helpful to everyone. I think that's all the time we have right now for questions. I would like to thank you, the webcast faculty. Thank you, Kathy, John, especially thanks Susan for being brave and for sharing your experience. And thank you, Cure Duchenne, for all that you do for Duchenne and for families and for the caregivers and for us, the provider. Thank you for joining us.
Thank you very much. Yeah, thank you very much, Dr. Ciafaloni, for hosting the program today, and thank you to all the panelists also. We really appreciate it. Our son, Hawken, has been on Flazicort since he was diagnosed 15, 16 years ago, and he's been able to mitigate the side effects very successfully with a combination of diet, human growth hormone, Fosamax, and a lot of daily stretching. So we feel very positive about this therapy. And I'd also like to thank PTC Therapeutics and Sarepta Therapeutics, both of whom provided unrestricted educational grants to make this program available. And this program will be archived and available on the Cure Duchenne website at cureduchenne.org/cure/webinars. And you can also view it through the archived webinar at the Duchenne Exchange, which is a dedicated online platform for the Duchenne community. It's duchenneexchange.org. And following today's webinar, we'll make available a free steroid guide for all participants and others. And we'll email you to let you know when the card is available and how to download it from both cureduchenne.org and duchenneexchange.org. And in addition, I'd like to mention PJ's protocol, which has a lot of information, especially for emergency procedures involving steroids. So again, thank you for everybody for joining us. Thank you to the panel. And with that, I will say good night.
This concludes today's webinar. Thank you.